And I think I'm right on time, so I can take some questions, comments, and at least hear some from the great brain power in the room. Okay, too much food for thought. You're digesting, huh?
Dr. Levine, thanks very much for some
Good morning.
pretty provocative thoughts. Good morning to you, too. So what would it take, do you think, for us to stop counting the way we do now and to switch over?
Great question. So I think at the root of this, the issue is our culture. We have created a culture, and it's ingrained. And my favorite Mark Twain quote, I may have quoted this to groups before, but he said, "The less there is to justify custom, the harder it is to get rid of it." And in effect, we are really fighting an upstream battle, an uphill battle. And we need everybody in here to work with us, because I think about data collection as so ingrained, particularly in the work of health and public health and healthcare, that sometimes we don't even stop and think about the impact of how we're collecting data. So all I can say is we have to start raising awareness, and we have to get to that tipping point where enough people say, aha, and enough. And I think it'll happen. Unless you have other good ideas.
Hi, I'm Suzy Lee with Potomac Health Foundation. Do you have examples at the state level that folks more working at the regional or local level of what you're doing as at the Department of Health with your counterparts that aren't traditional health partners, and are they buying into the message? Because I think for us to see that at the state level is something that would be really encouraging, and things that we can take back to our own groups that we work with.
Yeah, very good question. So a critical piece, I'll just go back to this slide here, the very top, the health status assessment. If local leaders or at a regional level, collaboratives and coalitions are going to try to make better decisions, they really do need to be data-driven and based on the best evidence we have. So we believe that every one of our 35 health districts should have a robust community health assessment. And that's an assurance role, I think, of the health department. It doesn't mean that we will do it, because there may be other entities, nonprofit hospitals, collaboratives, foundations, that can lead that charge. But I think we have to assure that we know what every community looks like. And the critical discussion that's happening at the state and at the local level is what should be in that assessment. So we're stuck a little bit because right now we want to make sure that the data that we have is available. And that's a start, because you have to look at the data and come to grips with what you have and what is it telling you and what is it not telling you. And then create that platform in which we can add or connect to other databases. I think this is really crucial. About a year ago, when we polled all of the health districts, only about a quarter of them had actually completed a health assessment, and we're on track that all of them will have a health assessment as a collaborative effort, and that health assessment will utilize data that we already have and will connect with other databases, some of which are at the state level. So for example, we have a lot of healthcare workforce data at the state level, but it's not necessarily utilized. So if we can integrate it into a community health assessment and make it more available, it's part of the asset picture of that assessment, because the assessment shouldn't just be a needs assessment, it should also include asset. But I think the real challenge as localities and regions get together and start to look at their community assessment is to ask the very questions that I'm posing to you. Is that really what we need to know? Is it providing the picture of health? Is it giving us the ammunition, so to speak, to do the work around the other critical determinants of health? And I think that at the local level, you can help us at the state level to create the templates and the processes so that we're collecting the right information and providing that back. I think at the end of the day, we'd like to make that work a little less front heavy at the local level. I think there's always a need for community input, no question, but we should be able, maybe through electronic health records and using the health information exchange, to aggregate that data better so it can be utilized at the local level. That's a bit of a short-term leading to a long-term look, but I think it's a critical piece for mobilizing communities to act and get away from opinion-based decision-making around health improvement.
Hi, Nancy Freeborn from Greater Prince William, formerly from Fairfax County. Question related to best practices in other states. I'm attentive to your ranking us 21st. Other states that have rich cities like California and New York, do they have best practices for statewide despite the diversity of the state resources?
So actually, there's in those states that you mentioned, there's still quite a bit of disparity. But I think some of the policy decisions that they've made are impacting that, and time will tell. So you may have heard of the delivery system reform incentive payment process through CMS. States like New York are actually looking at ways to take savings from their delivery system reform and investing it on the front end in more primary prevention, which gets into the things I think you'll be talking about today, which is how do you invest in your communities to either redesign communities for walkability or other social determinants. And we in Virginia have not yet gotten to that point where we identify the savings and then can reinvest them on the front end, which I think is a critical piece of what we have to do. So states like New York, I think, will provide some opportunity for us to see how it works, but the politics are very different there, and so we've got a bigger struggle. At the end of the day, though, if we can get people the right care at the right time at the right place and save some of those healthcare dollars, I think that the healthcare systems, through maybe accountable care organizations or other entities, would be willing to invest those, businesses would be willing to invest those dollars on the front end if it knew that their employees, their patients would be healthier. And I think that's where the opportunity is. But quite frankly, the conversation has to start at the local level, and I think that's what will drive the policy decisions. And you're sitting right next to Senator Barker, so I know he's already thinking about this. But I think all of our local and state legislators need to see evidence of that and understand the impact and the power of that level of investment. And our data, quite frankly, has to demonstrate too, and perhaps data from other states, that there is a rich return on that investment, because at the end of the day, I think it's about people being healthier. Oh, and by the way, yes, we may actually save some dollars in that and can invest it on the front end. Anything else? Oh, in the back.
Hi, I'm Donna Marie from the Community Foundation. Just wanted to understand, where is behavioral health in this health-connected communities, and is Virginia doing anything around trauma? Folks are talking, a lot of states are really addressing trauma and how that impacts health.
Absolutely, great question. So the quick answer to your question is behavioral health is everywhere in the plan because it's an underpinning issue. And we actually have, the plan is based on a series of metrics. The metrics started because the Joint Commission on Healthcare asked the Health Department to lead an effort to define population health metrics for Virginia. So we actually have metrics in all of those aims, the key components of the plan. And one of the metrics is on adverse childhood events, and the ACEs as it's known, and the impact. But there also is a specific metric on behavioral health and substance abuse hospitalizations. It's maybe not the best metric, but it's a metric that we have that captures it. And quite frankly, if you look at the data on substance abuse, particularly heroin overdose, every audience that I'm in front of, I have been showing the dramatic increase in heroin overdose, not just deaths, but emergency department visits, which for the first 5 months of this year is one of the most steep increases that I've ever seen for any public health issue, and I think it's incumbent upon all of us to take this as a public health crisis and run with it. But when we look at the data for preventable hospitalizations, more than 50% of those hospitalizations have a behavioral health component. So it's likely that if we dealt better with behavioral health on the front end and helped get people the care they need at the right time before they're in crisis, we would significantly impact preventable hospitalizations in the Commonwealth.
Don Ryan with Rebuilding Together. I love your observation that the way we categorize things hampers our thinking about what's possible. I want to put in a plug for housing quality. Housing is always mentioned as a social determinant of health, and it's always lumped together with income, poverty, transportation. We know, the science tells us specific factors in homes that affect all of our health, all of our homes, and the effectiveness of a wide range of interventions to reduce those risks, many of which are almost ridiculously common sense and low cost. So I guess I just want to challenge our thinking that housing is not an intractable problem. It's not somebody else's job. There are ample opportunities, and I just wonder, in terms of the way we talk about it and the way we collect data, if we might look more specifically at ripe opportunities in housing. The community health assessments, most of them gloss over housing, and the truth is there are specific opportunities in new delivery systems that can make a real difference.
Great point. I hope you all heard that about housing and its impact. So housing is a component of the Health Opportunity Index, and we could have pulled it out, and I think we'd see the same issues. What I would ask you all to do is something that I did a couple weeks ago with the medical directors for the major insurers in the state. Because outside of Virginia, we have insurers who have seen exactly what you said, and they realized that it's a better investment for them to put their dollars, their premium dollars, into housing for their members. And that at the end of the day, they've been able to demonstrate that by providing housing, by paying for housing, they had better health outcomes, period. So I challenged all the medical directors to take a step back and get beyond just the health care initiatives that they're looking at and really work the way many of these other insurers have done, because they have the money to do that, and at the end of the day they're looking to make sure that their members are healthier. So that's only good for the insured population, but if we get them doing that, I think that at a community level, others, like members of the business community, might find that really impactful and work on it too. So I couldn't agree with you more. I thank you for bringing it up. I believe there are states like Utah that have actually put state dollars into providing housing and found that that was a better investment than paying other social benefits, and that the other social benefit costs went down as a result of that, because once they developed the housing, they wrapped around services, and people were better off and quite frankly became productive members of the community. So couldn't agree with you more. Well, thank you very much. I'm looking forward to Dr. Wolf's talk. I think I've teed him up well. And I'll turn it back to you, Pat.